So this is where I kind of start to go, dang it. Okay, with great power comes great responsibility. We really need to be delicate in the use of some of these supplements that we have that are very powerful. Because, again, first do no harm, all these little things we say in our head to keep us accountable. Are we by chance causing harm? Are we reducing? So the other thing homocysteine doesn't just play into to the SAMe pathway. This is complicated biochem, but it also gets converted via another pathway called the transsulfuration pathway into glutathione, which is our most powerful antioxidant in the body. And in pregnancy, glutathione levels elevate exponentially to compensate for that high amount of oxidative stress that's being produced through all of this embryonic placental development. We see that in fertility. Our eggs and our sperm need lots of glutathione. That little embryo gets kind of stuck doing its own thing, living off of glutathione until that placenta is fully developed at 9 to 12 weeks. So that little embryo during all of that development is producing a lot of reactive oxygen species that have to be neutralized until that placenta opens up. And guess who does that? Glutathione.
Welcome to the Rewire for Birth podcast. I'm your host, Dr. Cindy. I'm a naturopathic doctor and birth guardian, and I couldn't be more thrilled to have you here. This podcast is all about rewiring the way we think about pregnancy, birth, and postpartum by offering a holistic perspective that empowers you to embrace your journey with confidence and strength. Each week, I'll bring you expert insights, valuable advice, and inspiring stories to help you feel prepared and empowered. We'll dive deep into the transformative experience of bringing new life into the world and explore ways to make your birthing journey truly beautiful.
Please remember that although Cindy is a naturopathic doctor, she is not your naturopathic doctor. This information is made available to you for educational and informational purposes only and should never be used as a substitute for medical advice. Please see rewireforbirth.com/disclaimer for details.
On this episode of the podcast, we have Sarah Thompson. Sarah is a licensed acupuncturist, a certified functional medicine practitioner, and birth doula with over 20 years of experience in maternal health. She is the author of Functional Maternity and Beyond Results, both of which are used as textbooks in midwifery education. She also teaches continuity education courses for midwives and other birth professionals through her Functional Maternity Academy and the Colibri International Birth Institute. Sarah integrates functional medicine, nutrition, and traditional therapies to support evidence-based whole person maternity care. Get ready for a jam-packed episode full of practical information that you can implement. We dive deep into nutrition. We dive deep into the processes of the body. We dive deep into how pregnancy is a unique state that should be treated differently than other phases of our life. I am so grateful and so blessed to have co-created this episode with Sarah. Let's dive in. Okay, we are welcoming the fabulous Sarah Thompson to the podcast today. I'm so excited because we are going to get into the nitty-gritty of so many things that we don't get to talk about often on the podcast. And we are welcoming all of the nuggets of wisdom that we're going to hear today. So blessed that you are joining us amidst all the amazing things that you're doing. And I want listeners to know before we get started that you have an incredible resource out there called Functional Maternity, your book. And it is all about using functional medicine and nutrition to improve pregnancy and childbirth outcomes. My curious inner child is just beaming with joy right now, like it is my birthday party or something. I'm so excited for this. Welcome, Sarah, to the podcast.
Thank you, Cindy. It's a pleasure being here.
Amazing. So as we get started, I want to start very basic. I want to start with prenatals, if you're okay with that. Let's dive in, let's flesh it out. I'm just putting myself in a place I was once upon a time, and that so many moms to be find themselves in. They're like, what do I even look for?
It's such a loaded question because everybody's nutritional needs are really unique and dependent on a huge number of factors, whether that is what they brought in with genetics, what are their dietary patterns, how much did they work out. There's a lot that plays into what somebody actually needs during their pregnancy. And I always think of a prenatal vitamin as the safety net. This is to help cover any of those days where you may not be doing so good, or to fill in the gaps, maybe even from a genetic perspective, that happens to be your nutritional Achilles heel, per se. But it shouldn't be taking over for diet because you can't supplement your way out of a bad diet, is kind of what I always say. And there's so many amazing things that come with our food that are so much bigger than just vitamins and minerals. We have tons of phytonutrients that we don't even know a ton of information about. In fact, it's like an iceberg of information. We know this much about our phytonutrients. I went to a conference years ago, and the entire conference was based off of antioxidants. And the keynote speaker who gets up and she's like, see this graph? This is a list of all of the phytonutrients and antioxidants that we know about. However, we have researched and we have named and we have labeled less than 1% of those,
Wow.
right? So there's a huge gap in our knowledge of what food gives us. And I feel like if we focus so much on individual nutrients, sometimes we miss that big picture of what the entire meal can give us if we try to eat those nutrients in our food. So that's my long-winded way of saying when we look at prenatals, again, it's not this idea of let's hit everything we could ever possibly need in a pregnancy in a multivitamin. It's what does this person need necessarily to fill their gaps, and which nutrients maybe are we the most concerned about, and those are the ones we want to focus on. The prenatal vitamin world out there, there's so much variation on what's available and the quality and the quantity of the nutrients in there. And I think the most important thing for people to look at when they're looking at a prenatal is comprehensive prenatal. Something that gives you a little bit of everything, a lot of everything, depending on what you got. Most of the prenatals that unfortunately are given by our medical providers are pretty basic. And there's a lot of gaps that need to be filled there from a maternal nutrition side of things. There's a very big difference between prenatal nutrition and maternal nutrition as well. And hopefully today we'll dive into a lot of that maternal physiology and those unique nutritional needs that moms have that babies don't. And most prenatal vitamins, especially the ones that are pretty basic, I don't want to throw names out there, are designed for baby growth, not mom growth. This is why when I talk, I'm always talking about let's go into maternal care and what does mom need? Because if we can get mom's nutrition looking good, then baby's going to be just fine. But if we focus so much on baby, there's so many things that mom needs that baby doesn't need. And we're going to miss a lot of those nutrient needs for mom, and mom's going to struggle, but baby's going to be fine. So when you look at a prenatal vitamin, again, the most encompassing of prenatals is probably going to give you the biggest bang for your buck. Some of the big things from a nutritional perspective that we want to make sure we're covering also depends on trimester. And there's a couple of those prenatal brands out there that have actually made trimester specific prenatals, which I kind of like. I don't necessarily agree with everything they've got in their formulas per se, but I like the idea because each trimester we actually need different things. Our body's metabolism, our body's needs from a physiological perspective do change. A lot of people don't even take a prenatal in the first trimester because there's such a minimal demand for some of these nutrients. That being said, on a general basis, some of the big things that we think about are, say, the vitamin D component. A lot of prenatals don't give enough vitamin D, and what we have found in the research is it takes about 4,000 international units of vitamin D per day to maintain levels in pregnancy. So that's something we're starting to recommend more and more in pregnancy. I'm a test, don't guess person because you can overdose on vitamins too. So always have somebody test their vitamin D at an OB panel, that 12-week blood work, and that'll help you determine, do they need additional support? Right? Maybe we need a little bit more, maybe we need a little bit less. It's all variable there. Obviously, the biggest things we think about are B vitamins. B vitamins play into metabolic processes, and there's a huge increase in the need for our B vitamins throughout the course of pregnancy. It's like a 6-fold increase in folate, a 2-fold increase in B12. So there's some huge changes that happen as we go through the course of pregnancy. Vitamin C, antioxidants, I think trace minerals are always important. We're seeing more and more research on things like manganese, magnesium, selenium, all of those. Iodine is also important. The thyroid is going to be asked to do 50% more work in pregnancy. So giving that thyroid the nutrients it needs. There's also studies that talk about iodine deficiency in pregnancy, regardless of thyroid function, being associated with infant IQ later. Iodine deficiencies in mom during pregnancy, regardless of thyroid function, is associated with lower IQ later. So we do talk a lot about dietary, making sure they're getting a lot of these foods in their diet, but from a supplemental perspective, making sure they're getting that 200-ish micrograms of iodine in there. There's such a big variety, and some of these things I'm talking about aren't going to fit with somebody, or they feel really bad on prenatals. And there's usually a reason for that. I'm not a big fan of iron in a prenatal.
Say more about that.
Yeah, I think that should be a separate pill. One is iron is really difficult to absorb. There's a lot of nuance to iron absorption that I don't think people are aware of, because the body has a really strong regulatory mechanism against iron because iron is toxic. I don't think people realize that. Iron is oxidative. It's actually the primary action of iron in the body is to create oxidizing reactions. I always explain it like this. What happens to a cast iron skillet if you get it wet and you leave it out in the air? It rusts. That's what iron is doing in our body every day, just through its normal physiological function. And that oxidative stress or that rust in the cells can cause a lot of tissue damage. And so the body is very, very sensitive to the ebbs and flows of iron. And so our body's ability to absorb iron is best first thing in the morning. Then throughout the day, it wanes as hepcidin levels rise in response to the amount of iron that we consumed earlier. In pregnancy, I always say, take everything you know about nutrition, and as soon as somebody gets pregnant, just throw it out the window, because pregnancy changes everything. In pregnancy, our bodies become even more sensitive to the ups and downs in these iron levels. And nothing is more extreme than what happens in the first trimester. This is why I don't like iron in a prenatal, because once we get into first trimester, we're going to have to stop that iron anyways, because the body naturally suppresses iron absorption. And we'll see iron absorption dropping to about 1 to 2%. Outside of pregnancy, iron absorption, if we're looking at non-heme based iron, is 5 to 15%, and then heme based iron is about 35%, give or take. And in the first trimester, this drops to like 1 to 2%, because our babies are very, very sensitive to oxidative stress at that time. And so the body says, no, thank you. I don't need that right now. I've got ferritin reserves to pull from. I would actually like to have lower iron levels in the bloodstream, because too much iron in the blood may actually damage the embryo and the placenta in those early phases when they're producing so much inflammation during that early embryonic development. And then we get to 12 weeks, once that placenta opens up and we've kind of circulated some fresh blood in there, and the body says, oh, I got to recover from that. Hey, remember that time I stopped you from absorbing iron? Yeah, about that. We're going to have to bring some back in, right? And we have to recover from that. We see a huge uptick in our ability to absorb iron. And then as we roll through pregnancy, we get to third trimester, and this really cool, unique thing happens where non-heme iron absorption actually becomes better than heme-based iron absorption. So we find that non-heme iron absorption goes from about that 5 to 15% that we see outside of pregnancy to something up towards between 60 and 70%.
Oh my gosh.
This is huge, right? where heme-based iron absorption stays about the same, that 35 to 40% absorption rate. So while heme-based iron stays here, you've got non-heme iron absorption just skyrocketing in that third trimester. And so your actual dietary needs for iron, yes, that third trimester becomes a huge part, but it's actually a higher desire for that plant-based iron, which is super interesting. And
Mhm.
this comes from the physiological changes. At third trimester, most of that heme-based iron is going directly to the placenta and directly to the baby whole. Mom's not even going to use that heme-based iron. Her body is going to function more off of the non-heme iron, where it's going to come into the system, it's going to go into the cells, it's going to go get stored into ferritin, and then that ferritin is going to get broken down to also go to our baby. Babies have to accumulate 350-ish milligrams of iron before delivery, and most of that is done in that third trimester. So that iron absorption is kind of in two ways. You've got heme coming directly to baby, and then that non-heme going to mom first and then coming to baby. So it's kind of a
Mm.
really cool system when you think about it, but it changes our nutritional needs if we take into account mom. If we just take into account baby, that's a different nutritional need and at different times, right? So this is where we look at these prenatals and we look at nutritional needs. And again, that prenatal is a safety net, right? That's all it is. It's not going to hit 100%, nor do we really want it to. It's the diet that we have to kind of focus on. And then we add other supplements in if we need it. If somebody is iron deficient as we roll into third trimester, that's a time and a place for an iron supplement.
Mhm. Yeah.
We also find studies coming out of India now where they're really big on prophylactic iron supplementation because iron deficiency is such a big thing out there because they just don't have a lot of iron-based foods in their diet. What they find is iron supplementation in cases where iron deficiency isn't present may actually increase the risk of things such as gestational diabetes and preeclampsia
Oh, wow.
because iron is toxic.
Mhm.
It creates iron-induced cell death. It's one of the mechanisms of regulation of aging of cells is these hydroxyl groups that are produced by iron oxidative reactions. So it's a very interesting and kind of delicate system, which is why I don't recommend prenatals that have iron in it, right? I want that iron out. I want to be able to control that and give it to somebody if in fact we need it.
And in comes the testing so that we understand what we're working with and what trimester we're in and all of that. It just takes me back to my experience where no matter what I did, my iron levels were not coming up. And
Yeah.
it makes so much sense about what you're describing, how the body is so tightly regulating that iron absorption and opens up that regulation a little bit more loosely towards the end of the pregnancy. I love the nuance that you bring in of the prenatal focus, the focus on the baby and versus the maternal focus. We are so often trying to prevent certain things for the baby without so much concern or focus on the mother's health. And as we know, just being in this world, the mother's health is the baby's health, right? So bringing the two together and making sure that the mother has everything that she needs to be able to gestate this new life is really important. I also want to circle back to vitamin D because you mentioned 4,000 IUs, which is so much higher. And even I have a hard time seeing prenatals with 1,000. Actually, maybe that's a little bit more common, but definitely not more than that. What do you see typically in most prenatals?
Yeah, you'll see anything from like 600 IUs, maybe even 400 IUs, all the way up to that 4,000 mark. There's just such a broad band of availability on there. This is something that you take into account the individual, right? Not just the testing, but where do they live? What is their lifestyle like? Are they outside a lot? Are they going to get a lot of sun exposure? If they're outside a lot, are they using mechanical sunscreen or real sunscreen? Are they putting hats on? Are they putting shirts on to cover their skin? Or are they putting a lot of actual topical sunscreens on because that changes their actual needs for vitamin D? Where do they live in the world? We find that people who live above the 37th parallel, the parallel are the little ladder lines that go across the world, And where I'm at here in Colorado, we just make the cusp of getting above that 37th parallel. People who live above the 37th parallel are more likely to have vitamin D deficiency just based off of the sun schedules and how we start to get shorter light periods during the winter and things like that. We also find that there is like this altitude part to vitamin D deficiency too. So there's like this sweet spot in where you live in the altitude that you're just not going to get the right UV rays to make enough vitamin D. So if you're at sea level, you're a little bit better. And then if you get really high, you almost get too much. So there's like this sweet spot where I'm at in Colorado. This is kind of that spot where we say geographically, we are prone to more vitamin D deficiency just based on our lack of sun exposure. So these are also factors to take into account as to, does somebody need a prenatal with that robust 4,000 IU, or do they live in Florida and they go to the beach every day and they're living their best life and we're all jealous and and they don't need as much vitamin D because they are getting the sun exposure. They're eating fish 3 times a week. They throw mushrooms in their soups, all the things that we would think about for vitamin D consumption on top of sun exposure. Then they probably would do better on a prenatal with less vitamin D because, yes, you can overdose on vitamin D. So again, as we look at those prenatals as practitioners, our job is to make sure we are using these supplements just like we would medication. With great power comes great responsibility, right? And we can hurt people with supplements. And taking into account the individual lifestyle, their diet, all of the things to make that decision on what is best. When I talk to individuals, I always say, be realistic with your diet, be realistic with your lifestyle. If you feel like you are doing these things, then be careful with some of these souped up supplements. If you aren't consuming these things, you're not a fish eater. That's okay, right? You just might need to have a little supplement in there to compensate for that, or find food sources that do fit what you need, that just aren't fish. But if you aren't a fish eater, you probably are going to need more support in some of these nutrients. So being realistic with diet and lifestyle. Yeah.
Yeah, absolutely. I love that you remind us that these aren't just like Tic Tacs that we're popping. These can actually make a physical difference throughout your experience and impact birth outcomes, which we're going to talk about later. But right now, I want to just tune into those women who are feeling like they've had a great lifestyle, they've had a great diet, but comes the first trimester and they can hardly get up. They're feeling nauseous all the time. They can't cook themselves a decent meal. They're trying to pull on supports, but maybe their support network isn't that robust just yet. And the prenatal is their saving grace in a lot of ways. And some prenatals can even exacerbate that nausea. For those people who might be listening right now, what are some of your recommendations just to get some kind of nutrient dense food in, or to just kind of dampen the intensity of the nausea? What do you see in that kind of demographic that is helpful?
Sure. So I think that when we talk about pregnancy nausea, obviously there's a wonderful U curve here where when somebody has no nausea, I kind of get a little concerned. Like we should have a little bit of food aversion in that world. You should have some cravings into a specific pattern of cravings, which tells me your physiology is doing what it's supposed to do. On the flip side, if we're going the other way and your body is not wanting, it's rejecting everything, we have a problem there. First trimester is a grace period when it comes to nutrition, especially when it comes to our baby. Most everything that embryo needs to grow is already with it. It came from the months preconception. And in order to get nutrients to the growing embryo, we have to have a placenta at this point. So everything that's going into nutrition in the first trimester is based on growing a happy, healthy placenta. And this is very basic nutrition. This is where I say, if you can't take a prenatal, do not stress it. It's okay. You're going to be okay. Bad things aren't going to happen if you can't take a prenatal because you're nauseous. And oftentimes people who are nauseous do worse on the prenatals because their body is like, no, thank you. A lot of times nausea is a reaction to the toxicity of pregnancy. Now, pregnancy is a toxic event. It is a state of oxidative stress. It is a state of insulin resistance. There's a lot of these things that we see as normal maternal physiology that outside of pregnancy, we'd be like, that's bad. But in pregnancy, it's totally normal and we expect it and we want it. On the extremes side, there are mechanisms at play in the brain and in the body that tell us to reject things that are toxic. And for some people, this natural evolutionary biology, which is designed to protect that embryo from anything that could poison it and make it not survive, becomes extreme. From a genetic perspective, we do know that there's a specific gene now that we find associated with more hyperemesis, and it creates a similar reaction to what we see with chemotherapy-induced nausea, where it's a toxic-based nausea, where the body is like, oh my God, there is something in me that's toxic. We have to vomit it out because that's how our body purges things that are toxic. If you get into something that's a food bug or you consume too much zinc, my daughter, I have a wonderful story about her taking too much zinc and she ended up having a horrible episode of nausea and vomiting. And she was like, I don't know what happened. And we were running through what she did and she'd taken a 50 milligram zinc and she really shouldn't have done that. So that is how our body purges things to be toxic, right? And so when we're looking at the morning sickness side, that is sometimes a reaction, and zinc becomes a very big trigger. There's usually prenatals with huge doses of zinc in there. 15 to 30 milligrams is not uncommon. That's going to make your nausea worse. Iron, we just talked about that. Iron is a huge trigger of nausea in pregnancy because your body is dropping that absorption to 1 to 2%. It just sits heavy in the stomach. This is why so many women have aversions to red meat, zinc, and iron. Iodine can trigger nausea in the first trimester. And it does so because that thyroid just got revved to 35%. And part of that revving of the thyroid is an increase in the reverse T3 and a loosey-goosey iodine that gets pulled off of the T4. That higher iodine level feels toxic. Our body's way of stopping that is to purge. What is it? 2/3 of all hyperemesis cases can be connected to a hyperthyroid situation in that first trimester. So it's quite a few. By cutting out iodine, we can help reduce that. And we think of all of our iodine foods. Most of these people are going to have huge aversions to in the first trimester. Fish, seafood, right? I think everybody I've ever met says no thank you to seafood in the first trimester. For some people, that ends up being legumes. For some people, that ends up being eggs. There's a lot of these foods that are very iodine heavy that sometimes become those food aversions in that first trimester. That's one element of reactions in that first trimester. The other things that we see are often associated with blood sugar regulation. And hypoglycemia, low blood sugar, is one of the other most common causes of morning sickness. And as we talked about that thyroid getting revved, with revving of the thyroid comes revving of those mitochondria, because one of the primary jobs of thyroid hormones is to genetically express the mitochondria in the cell. The mitochondria is where we're going to take our calories and turn them into energy. If you remember Biology 101, this is the Krebs cycle, the electron transport chain, all these great things that play into metabolism. We find that the nutrients that play into energy production are the ones that become the most important. This becomes a lot of our B vitamins, and it's our non-folate B12 B vitamins. It's those other ones that nobody ever talks about. Thiamine, riboflavin, pantothenic acid. Those B vitamins become the ones that our body really needs the most of for revving those engines. CoQ10. There's a lot of these nutrients, vitamin C, that fit into that pattern. And with that revving, we need those nutrients, but we also need the calories. And this is why almost everybody you talk to in the first trimester, what do they crave? Carbohydrates. They're like, I feel horrible because I was doing so good with my diet before I got pregnant. And now I am emotionally filled with guilt because all I want is a bagel and cream cheese.
Yeah.
And I haven't had a bagel in 6 months.
I loved bagels when I was pregnant.
And I joke, in the first trimester, a bagel and cream cheese goes a long way. It's almost like the perfect first trimester meal because it's high carbohydrate, which you're going to suck those carbohydrates in. They're going to raise your blood sugar and they are going to tank fast because all of that sugar is going into the uterus to rev that cellular development. Making a baby is not a slow, steady process. Making a baby is rapid cellular energy. And we don't have time to break down fats and proteins in metabolism to make enough energy to grow a placenta or an embryo for that matter. We need something fast, and glucose is that fast energy. We find that the HCG in pregnancy actually increases insulin sensitivity in the body. So it's just sucking that glucose out of the system. Now you take that bagel and you pair it with a really good fatty cream cheese, that's protein and fats, and that helps to slow that carbohydrate into the bloodstream. We ration it a little bit. Okay, here you go, bloodstream. We want you to have all of this, but we want you to do it in a controlled manner because we don't trust you right now. Okay, because you're a little out of control. So we're just going to feed you a little bit at a time. So we don't get that high up and we don't get that high down, because the high up and the high down, both of those are going to cause more nausea. We need the carbs, but we have to stabilize it with a protein and a fat. Other things that I have found really beneficial in the first trimester, and again, this is all patient dependent. Some people, this is going to feel really good. Some people, it's not, is fruit. A lot of people do really good on fruit. And I feel like there's two different forms of nausea. There's hot nausea and cold nausea. I think from my TCM background, we tend to describe things based off of temperature a lot, but it ends up being people with like hot nausea. They do really good. They're craving cold things all the time. Like ginger does not do good for these people. It almost makes their nausea worse because ginger is a very hot herb. But they do really good on fruit. They do really good on smoothies. They're craving almost that cold type food on a regular basis. And then you have the cold-based nausea, where something like ginger actually might be beneficial for them, where they are not okay with maybe some colder stuff and some warmer foods, actual real food, cooked food feels a little bit better, right? They do good maybe with rice bowls and congees and those sorts of things. The idea, though, is that there has to be a good amount of carbohydrate there. And this is where a lot of people who I work with people on all fronts, but I feel like there's this huge group of people now that I'm starting to see that have been actually eating a healthy diet. They've been doing what they've been told, and they get into this first trimester and their body's craving these carbs, but they have not been on a high carb diet in a very long time. They can't even remember the last time they had a grain. And now their body wants pasta and their body wants bagels and it wants all of these things. And there's a reason for it. We have to kind of feed that beast, but also control the beast a little bit, right? It was a horrible study done, but I always reference it on morning sickness. They compared what they called a high protein meal with a high carbohydrate meal and concluded that the high protein meal was better at controlling nausea than the high carbohydrate meal. And I know a lot of people have latched onto this study because that was the findings of the study. But I always say you got to get to the nitty gritty of what they actually looked at in these diets. What they considered the high protein diet was an omelet, so eggs with some veggies in it, a side of fruit, and a piece of toast. That was their high protein diet. They compared that to powdered lemonade.
Oh.
Yeah. And wouldn't you know it, the people who ate the high protein balanced meal with actually a lot of carbohydrates because they had veggies and fruits and toast had better control of their nausea than the person who just drank powdered lemonade.
What a shocker.
What a surprise, right? But because of that, I feel like a lot of people, and this is how it gets trickled down the system. Somebody hears they were taught high protein diets are better for nausea, but they don't know where it came from. It came from somebody who told them who was a creditable source. It's like a telephone game. But when you go back to where the actual guideline came from, the study's kind of flawed. And so when I look at that first trimester for a lot of people, and we have that nausea component, what I'm trying to do with them is to get the carbohydrates, but to balance it from a macro with the proteins and fats. But more importantly, make sure that those carbohydrates that they are consuming also give them the nutrients that they need for energy metabolism, right? It's got to be that good balance. What you find is actually rice and beans is almost the perfect blend for morning sickness and for those nutritional needs for the first trimester. Obviously, we would throw some veggies in there. Rice, beans, and greens goes a long way, is what I always say, right?
I love
But
that. It's a complete protein. It's
it's,
simple to prepare. Yeah.
yep, you can keep it in the fridge and pull it out. There's a recipe called Eight Treasure Congee that I recommend quite a bit. And it's a blend of several different grains. It's like rice, forbidden rice. I think there's some barley in there. You throw some legumes in there. I think there's azuki beans, there's cashews, and then they put the Asian dates in there, the jujubes.
Mm.
And it's got a little bit of that sweetness to it. We've got the carbs, but we've got enough nuts and we've got enough legumes in there that it balances it out. And that's something somebody can make in the crock pot, put in the fridge, pull it out and microwave it for a quick snack, take a couple bites of it here and there, and use something like that if it feels good as a filler in a meal throughout the day
Hmm. Yeah.
and still get a good array of vitamins and minerals and the things that their body needs at this time for pregnancy.
Yeah. I really love that you're kind of breaking it down by trimester, what the body is actually doing, what it needs, and also you're infusing it with your traditional Chinese medicine background of what state is this individual person's body in? What are their cravings actually telling us about the state that they're in? And how can we listen to those cravings? We're so programmed and conditioned to feel like cravings are just a weird thing about pregnancy, but it is actually a mirror of the body's internal wisdom telling us what it needs and what it doesn't need by the trimester, which is
Yeah,
pretty remarkable.
it is. And sometimes it's even day by day and week by week. I
Hmm.
kind of joke when you're pregnant, you're eating like a toddler,
Yeah.
where one day and for one week, you're like, oh my God, blueberries are the best food ever. And I'm going to have a pint of blueberries every day. And then you wake up one morning and you look at that pint of blueberries and you're like, I don't want that. That looks horrible.
Yeah.
Why, why would I ever eat blueberries? Right. But that salmon over there, now that's where it's at. Right. And it's this huge, like almost uncontrollable desire to fill this nutritional need. And once that bucket is full, your body says, oh, okay, we're good there. Let's move on. Oh, well, this is going to fill our need now too. And that's what happens with toddlers. Toddlers are known for that. And it's based off of their growth spurts, what they're going through in different phases of their development, that they need this specific nutrient. When it comes to like the blueberries, I've had clients where they're like, I just ate an entire bag of cuties by myself today. Is that bad? I'm like, no, that's perfect for actually where you are in gestation. Your body's asking probably for that vitamin C that you need for collagen stability. And when you know it, right now, your cervix is changing and remodeling, and you need some vitamin C for collagen stability. So
Wow.
it's pretty cool when you understand the physiology and those nutritional needs and you can kind of put it together. But the body is oftentimes smarter than we are. We just don't know how to read it.
Absolutely. Yeah. So, just a reminder to anyone who's listening to kind of take in the cues that you're getting from your body and be curious about what it may be telling you to consume more of, to consume less of, to integrate a little bit more into your diet, and really using your support system to help you, especially if you're feeling incredibly nauseous in the first trimester. You really got to tug on those support systems, which I always emphasize on this podcast. I did want to get into the tricky area that we find ourselves in often, because folic acid is so often put on a pedestal when it comes to even preconception health and obviously into pregnancy. And the emphasis is very much on nervous system development for the baby. And I want to just flesh this out. I want to dive into it with you. I know it's an area of controversy, so let's go there.
Oh, okay. So this is one of those topics that I always joke. I try to avoid this topic, and I know you and I touched base before, and I was like, I'm open to it. I've already opened to this can of worms one too many times because it is so controversial. And I'm one of the few functional medicine providers who may not actually like methylfolate in the way that we're currently using it. Okay.
Blasphemy.
I know, right? I'm waiting for the lynching squad outside.
Yeah.
Like it's bad. And I've gotten wonderful comments in my DMs on this when I speak about this. But I think it's because I work in pregnancy and I see this pattern more often then I see people who need additional folate. I see overdosing more than I see deficiencies. And there are detrimental things that we see clinically that maybe research hasn't quite caught up to, that I look at methylfolate and I kind of wonder if in 20 years from now, we're going to look back and regret the way we're using it within pregnancy with these high doses in some of these prenatals. And again, I always say with great power comes great responsibility. And methylfolate is a wonderful example of this. This is great nutritional power. And therefore, we have to take it seriously because we are bypassing rate limiting steps. We have designed this absolutely miraculous nutritional supplement for people who need it. However, the people who need it are actually not that many. So to blanket people with these really high doses of methylfolate, which is what we're seeing in some of these souped up prenatals, I think comes with consequences for a vast majority of people. And I don't think this happens quickly. This is not something that somebody starts taking one of these prenatals with methylfolate at a high dose when they find out they're pregnant and, oh my God, this is a bad thing. This is something that happens when people take these high doses over a long period of time, say in that fertility trial, right? That's when I think I see this the most. We can definitely dive into this, but folic acid also comes with a lot of negativity because it is also not the best. It is a synthetic, it requires multiple steps, and they're rate limiting steps in the breakdown of folic acid into tetrahydrofolate, which then gets to be used in with MTHFR, which is this gene mutation that everybody talks about, to go into the methionine cycle to take homocysteine and turn that into SAMe. SAMe's job is to go off into the body and deposit that methyl group somewhere in chemistry. And that could be in embryonic development. It can be in detoxification, phase 2 detox via the COMT gene, the COMT gene, and that enzyme. And then as it's done doing its job, it comes back and it gets recycled back into homocysteine. When we take methyl tetrahydrofolate, which is the methylfolate, we just kind of bypass this whole folate pathway and just say, let's just stick you right next to and with homocysteine to create the methionate and kind of push this SAMe cycle. In certain cases, this makes sense. And I know everybody out there is going to be, oh, but I have an MTHFR variant. That means absolutely nothing unless you have elevated homocysteine.
Mm.
And we see this in studies on pregnancy. We see this on studies on fertility. The only time somebody is going to have like MTHFR with a low homocysteine is because they have another gene variant up here called MAT1, MAT1. So there's this whole genetic world around methylation that is so much more than this one little gene enzyme called MTHFR, methyl tetrahydrofolate reductase. I'll have people coming in and their provider found a heterozygous 1298 mutation. And now they've been on methylfolates for a very long time. And I see this more so, I feel like, with people who have had secondary recurrent pregnancy loss. They have a child. They had a wonderful pregnancy. They're on the same natal that they started 3 years ago when they got pregnant with their first kid, and now they're having recurrent pregnancy loss. And we take them off of their methylfolate and they get pregnant and they don't have loss.
Wow.
I see this happening clinically. And one of the concerns is there's not a lot of research on what happens when homocysteine gets too low. And when you test homocysteine on some of these people who've been on a methylfolate for a very long time, they have what's called hypohomocystinemia. They have low homocysteine, usually less than 5, usually in the 4 range. And you take them off their methylfolates, their homocysteine jumps back up into the 6, 7 range, which is a healthy range. And then that's when they conceive. And so I've talked with other providers in the world about this too, that when you take these methylfolates, and if you're looking at the research too, most of the research that has been done on methyl tetrahydrofolate or methylfolate when it comes to pregnancy and in comparison with folic acid has been in dosages of 400 micrograms, not the 1,000 micrograms that we find in a lot of these prenatals. The 1,000 microgram mark has been used in people with MTHFR variants with elevated homocysteine only in research, not for the general population. So this is where I kind of start to go, dang it. Okay, with great power comes great responsibility. We really need to be delicate in the use of some of these supplements that we have that are very powerful. Because again, first do no harm, all these little things we say in our head to keep us accountable. Are we by chance causing harm? Are we reducing? So the other thing homocysteine doesn't just play into to the SAMe pathway. This is complicated biochem, but it also gets converted via another pathway called the transsulfuration pathway into glutathione, which is our most powerful antioxidant in the body. And in pregnancy, glutathione levels elevate exponentially to compensate for that high amount of oxidative stress that's being produced through all of this embryonic placental development. We see that in fertility. Our eggs and our sperm need lots of glutathione. That little embryo gets kind of stuck doing its own thing, living off of glutathione until that placenta is fully developed at 9 to 12 weeks. So that little embryo during all of that development is producing a lot of reactive oxygen species that have to be neutralized until that placenta opens up. And guess who does that? Glutathione. And so if we are low in glutathione, we have higher rates of miscarriage. This is why you'll see studies in B6, so homocysteine, we always talk about folate on this side. B6 is responsible for the first step. It's another gene called the CBS gene that goes into the steps that go into making glutathione. And we find that people who are B6 deficient, B6 does lots of other things outside of glutathione. People who are B6 deficient have a 40% chance of miscarriage. It's almost the exact same as people who have a folate deficiency. They're both about 40%. If you have both, your risk is 310%.
Wow.
So this is where this system is really important. We're talking about fertility, when we talk about pregnancy. I spend a lot of time talking about this specific biochemical cycle simply because it is so important for embryonic development, placental development, and maternal health in pregnancy. That little embryo has its antioxidant reserves that is going to help neutralize that pollution during its embryonic development so that it doesn't become toxic. If it doesn't have those, it's still going to go through all of those metabolic processes because it wants to develop. But there's nothing to grab onto that pollution. So it starts to accumulate pollution and oxidative stress. And the natural reaction to a buildup of oxidative stress is cell death. And so we see this sometimes in certain patterns of miscarriage, where the embryo is like, I got it, I don't got it. But we have a good placenta. Placenta did great because the placenta was being fed from mom. The baby was on its own until we got that placenta developed. And so what came with the egg and the sperm prior plays into that. The only studies we have on hypohomocystinemia for the most part are really old. They come from like the 1950s. And in those cases, it's related to a specific genetic mutation. And we've kind of talked about that little MAT1 or MAT1 guy up here. That is a very rare pattern. I've had a couple of clients pop up with a MAT1, and I can usually tell without ever having to test for the genetics now.
How can you tell?
It's just how they respond to the supplements.
Okay.
So if you have somebody who's on a methylfolate and their homocysteine is low, most of the time when I see that, they're like less than 3. I've seen people who are less than 1 in these scenarios on their homocysteine. You take them off of that methylfolate and their homocysteine actually gets worse. It goes down further. That's usually indicative of something else. That's not an overdose on methylfolate. There's some other issues in the system. The other thing with the methylation system is, I don't know if you guys are familiar with the movie 300, but I use this all the time. The gods saw fit to give us a spare, right? We have 2 different pathways that also help break down homocysteine into methionine. We talk so much about the folate pathway, but we also have the choline betaine pathway. So for a lot of people who have things like the MTHFR variant, they may have a really awesome choline betaine pathway that's actually compensating for it.
Hey mama, are you ready to transform your birthing experience? We're offering a free guided meditation to help you start rewiring your brain for an empowered birth. Imagine feeling calm and in control, embracing your inner strength, and making your birthing journey smoother and more joyful. Doesn't that sound amazing? It does, right? And it's possible for you. To get started, visit rewireforbirth.com/meditate and grab your free meditation now. Let's make your journey beautiful together.
You have this pathway that's revving really well, and so the homocysteine is not elevated. Therefore, that MTHFR is kind of null and void. You have a pathway that works. We don't need the other pathway. And this is nature's compensation, in a way, for that MTHFR variant. They're balanced. There's actually function there.
Wow.
Not a
Yeah.
problem. So
This is
again,
mind-blowing.
it's so complex that I get really nervous giving people souped up prenatals with some of these specific nutrients, and we're just talking methylfolate here, without understanding who they are as a biochemical individual.
Mhm.
I think there are great companies out there who have started to offer alternatives where they use a folinic acid instead of either folic acid or methylfolate, which is kind of a good middle ground because folinic acid has one rate limiting step, so it actually mimics normal dietary folate a little bit more accurately. It's a middle ground. So if you don't know where you stand, maybe that's a better option in a prenatal.
Yeah. Yeah. This is just reminding me of whenever we assume that we know better than the body, then we get these unintended consequences and outcomes. And it happens all the time. Learning how to see the body as having its own internal wisdom, which is a big theme that I come across over and over again on this podcast, no matter who I'm talking to, is what we need to anchor into. And it's very evident in the work that you do and how you're able to get into the minutia. Like, you're bringing me back to my biochem classes over and over again. What you're saying, with great power comes great responsibility. And there is an assumption, just because these are supplements and naturally derived nutrients and phytonutrients and minerals, that there's no real consequence. Just the emotional roller coaster of recurrent pregnancy loss is a very big consequence that we want to avoid. So thank you for bringing this to our attention. Thank you for going into it in as much detail as you are able to go into it, especially in the world of maternal health. I don't think most practitioners fully understand what we're doing. We just want to have these essential nutrients and minerals, and we're crossing our fingers that the body will do the rest. And sometimes it does, but we also have to understand what we're doing here.
Yeah, I brought up the telephone game before because I'm guilty of that. I feel like I'm guilty of that from a methylfolate perspective. Because when I was being trained, this is what I was told. Oh, this is the best. Oh, this is what you have to do because it bypasses this. And this is the difference we see. There's wonderful research that compares folic acid to methylfolate. And we do see methylfolate is better. We find better folate levels in folate RBC levels. The red blood cells have more folate in them. We see a better reduction in homocysteine with methylfolate. But those studies are done on people with elevated homocysteine, not people with normal homocysteine. Once I started actually doing the research myself, I started going, hold up, wait a minute. This is what I was told. But when I look at the study, this is what it's saying. And the two aren't actually diving exactly how I was told. Even with what I'm saying, I always encourage people, especially providers, to go and dig through all the research yourself, piece it together. The research is not put on a nice little platter for us. There's a little bit here, there's a little bit here, there's a little bit here, and we have to read it all to bring it together. I'm sure there's great studies out there that I haven't read, that I don't know about yet. And I would love if somebody threw that at me through a DM. Did you see this study? I'm like, yeah, I want to read that one, because that's part of our job, is to continually learn and to continually explore and to continually question, even if it's questioning what we've been told, so that we understand it fully, so that we can better serve our patients.
Yeah, absolutely. The curiosity and the continuous questioning of what just is commonplace, standard, routine is another theme that comes up a lot on this podcast. And I want to thread that into some of the birth outcomes that we are seeing often these days. High rate of cesarean births, high rate of interventions that we're seeing, high rate of women labeling their birth experiences as traumatic, like almost half, right?
Yeah.
And a lot of these interventions are because someone might be quote unquote high risk, or have gestational diabetes, or have preeclampsia, et cetera, et cetera. This is kind of getting away from the conversation of the birth world in general and all the unnecessary controversy in that world. But I want to know what you see in regards to prevention of preeclampsia, in regards to prevention of gestational diabetes, with your deep knowledge of nutrition and functional medicine.
Well, again, these would be very large topics to discuss here. Preeclampsia is something that I spend a lot of time on, simply because the rate in which we are seeing people being diagnosed with preeclampsia is exponentially rising. I think I saw something upwards of a 500+% increase in preeclampsia diagnoses since 1980.
Wow.
Now, with that, there's a whole handful of things that have changed, right? The average age in which women are getting pregnant has increased. We do see that the guidelines for diagnostics have decreased. So blood pressure levels don't have to be as high. I've had some clients who didn't even have the minimal markers of hypertension and proteinuria get diagnosed with preeclampsia, simply because they just had gestational hypertension. And their doctor said, well, we caught it early. And I think that those sorts of cases are also falsely elevating our preeclampsia diagnoses on paper. However, that being said, we are still seeing similar diseases, whether it's actual true preeclampsia or not, increasing exponentially. And there's a lot of factors that can be associated with that, depending on the pattern in which we are seeing that patient's preeclampsia, right? Gestational hypertension, that's a stress response for the most part. What kind of stress is it? Physical stress, emotional stress, where is the stress? For people with preeclampsia-induced hypertension, this is cardiovascular inflammation or cardiovascular stress. It is damage to the placenta, where we have vascular damage, or the placenta is starting to die. So the body is pushing really hard to get enough blood flow to baby through these teeny tiny broken blood vessels in the placenta. It's a structural stress. We also see other conditions, like you have kidney-based hypertension, where the kidneys are now saying, well, we're done. This has been fun, but we're going to give up on you for various reasons. We also see other things that don't even pattern into the toxicity realm being associated with hypertension. Certain nutritional deficiencies can mimic preeclampsia. Hypothyroidism, something that people don't even test for, most likely, when they have a sudden onset of hypertension in pregnancy. Hypothyroidism in pregnancy is associated with more gestational hypertension. And various reasons for that, from a cardiovascular to a kidney function side. But you will see, even outside of pregnancy, hypothyroidism in severe cases can mimic preeclampsia type symptoms, where you get hypertension and proteinuria. That can also play into labor and delivery. So many factors here. When we're looking at true preeclampsia, there's two things that we see pretty much evident in almost 100% of cases. One is what's called endothelial dysfunction, which just means the cells are sad. They're not functioning. That's like saying you have IBS. I know the bowels are irritated, but why? The other thing we see is oxidative stress. We kind of talked about that a second ago when we talked about iron. Oxidation, antioxidants, right? That whole balance between the byproduct of cellular metabolism and the ratio of antioxidants to neutralize it. There's something off in that system in cases of preeclampsia. If we want to dive into the whys on all of those, well, there's a great researcher. Her name is Nancy Hart. She does a lot of research into the lipid bilayers of cells in endothelial dysfunction as it applies to preeclampsia. She talks a lot about lipid balance, the balance between cholesterol, polyunsaturated fats, monounsaturated fats, and all of that in association with endothelial dysfunction and hypoxia and a lot of these things that go into preeclampsia. From an oxidative stress perspective, we know that in cases of preeclampsia, there are significantly lower levels of antioxidants and antioxidant-based minerals, things like manganese, selenium, some of these dietary minerals that play into antioxidant defenses. There's also the cardiovascular component. Some people are prone to endothelial dysfunction from vascular reasons, whether that is pre-existing conditions that they didn't even know about, things like antiphospholipid syndrome, lupus anticoagulant, some of these clotting disorders. HELP syndrome, gosh, if you've been following me on Instagram, I've been on a whole rant on HELP syndrome recently. But HELP syndrome often gets categorized with preeclampsia. However, it is an independent system. They can overlap because the mechanisms behind it are similar. We see those two same things, endothelial dysfunction and oxidative stress as the two primary things. The other thing we see in both conditions is oftentimes immune system reactions. So you can see the immune system basically overreacting to any element of inflammation within the cardiovascular system, being part of that HELP syndrome side of things. You can also see the immune system being a part of preeclampsia from a placental perspective. If the immune system is on heightened alert, which it should not be, it will attack the placenta. In pregnancy, the immune system is basically put on a forced nap. Shh, don't pay attention to what's happening over here. There's going to be some tissue damage over here. We just don't want you to react to that like we would normally. And that's thanks to hormones like progesterone. Progesterone suppresses the function of the immune system. When we have low progesterone, we can have more preeclampsia. And this is very well established in the research too. So many patterns that can play into preeclampsia. I spend a lot of patient time analyzing previous preeclampsia stories so that we can identify what happened so that we can prevent it in the next pregnancy. It's complex. The idea, though, is we have a handful of things. It's like one of those flow charts. Did you have this? Yes. Did you have this? No. And that helps you differentiate to the underlying mechanism. Almost every nutritional deficiency is associated with preeclampsia. However, treating preeclampsia with nutrition doesn't seem to make a difference because preeclampsia is a disease of the first half of pregnancy.
Yeah.
True preeclampsia developed preconception through 20 weeks. It's something that happened in the development of that placenta. So if you had a nutritional deficiency, say vitamin D deficiency, for example, highly associated with preeclampsia later in pregnancy, giving them vitamin D later does nothing for that preeclampsia presentation because the damage has been done. Now we're just managing through that damage. So when you look at the nutrition side in the prevention of preeclampsia, it's that preconception through the first half of pregnancy that becomes the most important. And I now know that everybody who's listening is going, wait, time out. You told me nutrition didn't matter in the first trimester. It does. In certain cases, there's these ideas of things that we really want to make sure that we're getting preconception coming into the first trimester because the diet and the swing of the body, it's not prioritizing that now. We should have had a reserve of these nutrients coming into pregnancy to sustain that first trimester when the body shifts its priorities into this over here, and it actually downregulates all these other mechanisms. So it's this ebb and flow. Once you get to certain phases of pregnancy, you almost can't fix it because your body has shifted its focus. It's like trying to fix a low ferritin in the third trimester. It's almost impossible to do because the body has shifted its focus. It's not in storage mode. Storage mode was up until about 28 weeks. Actually, storage mode was probably a little bit before that too, before first trimester. Now we are in a phase of we are taking in iron from the diet, but we are also breaking that ferritin down to give it to baby. And we expect a 75% reduction in ferritin levels throughout pregnancy because of that shift in our body's physiology. So you have to make sure that preconception, right? That's where most of this work has to be done. Coming into that first trimester and then knowing, okay, we'll do the best we can and get some fat soluble vitamins in there, make sure we're getting those obscure B vitamins nobody talks about, some of these trace minerals. And then once we get to 12 weeks, let's regroup, let's do some good blood work, and let's see how first trimester left you and what we need to do for the next couple of months to recover from that.
Yeah, what you're saying makes a lot of sense because even with baby aspirin or just aspirin that's being recommended to almost every woman that I know that goes into an OB's office, and even they state that it won't make a difference later in pregnancy. So you have to start earlier in the pregnancy. I have heard you touch upon calcium and preeclampsia and also comparing it to aspirin. Would you be comfortable just kind of briefly stating what you see and how that can be practically implemented for someone on their journey?
Sure. So when we look at calcium, it's like an overlap with baby aspirin to some degree. And baby aspirin, everybody thinks it's, oh, just the blood thinning aspects of baby aspirin that helps here, but there is an element of anti-inflammatory that does come with baby aspirin. And so we see that it reduces inflammation of those endothelial cells. So it helps a little bit there. We are finding studies that show that higher dosage, so not the 81 milligrams, but the 162 milligrams is more effective. We see a bigger reduction there. So when we look at calcium, and you'll see this with every single study on nutrition when it comes to preeclampsia, it only helps in people who had low calcium coming in. They have to be low calcium in the diet. If they didn't, then we may not see the statistical benefit that the studies are saying. I always give that caveat. So when we're looking at calcium, one of the things it does is it helps with regulating muscle contraction. It's that element of Goldilocksing things. We don't want it too hot. We don't want it too cold. We want it right. And I know I say calcium is good for the muscle contraction, but you got to have some vascular tone too, right? You can't just be all flaccid with magnesium. We use magnesium to over relax the blood vessels when you have acute, right, preeclampsia to prevent seizures and all that. We just shut the system down. Anybody who's been on a mag drip will tell you absolutely how weird their body feels because everything is just suppressed and flaccid. On the other side, we also have to have some tone because we have to be able to structurally push that blood through the system. It also seems to regulate the angiotensin system, which is the kidney's regulation of minerals in the body, so sodium and potassium and all that, which also regulates blood pressure. And calcium seems to have a little bit of an anti-inflammatory effect as well on the endothelium itself. So it regulates specific cytokines, particularly interleukin 6 is one we talk about a lot. Interleukin 6 not only plays into just inflammation in the body, but also messes with your hepcidin levels. So it can block iron absorption, which is kind of cool, right? When we see slightly higher interleukin 6 levels in pregnancy, when it gets really high, that can change hepcidin levels and iron absorption and stuff. When you look at the calcium side of it, it is more effective in people with a low calcium diet, right? You're not going to take a calcium with an aspirin and reduce that risk per se if that wasn't the issue. When you're looking at the baby aspirin side of things, it's also not perfect. You'll see studies that say anywhere from a 15% reduction to a 30% reduction. If you go up higher, and that reduction rate does go up from there. If it's not perfect, it's just the best they have. If we could take an individual, look at all of their things, take into account all the possibilities, and treat them correctly with that, then we might see better benefit. There's newer studies that talk about progesterone use in the first half of pregnancy, helping with the reduction of preeclampsia later. So there's a lot of nuances. And I know people are like, well, I had an IVF pregnancy and I was on progesterone until 12 weeks and I still got preeclampsia, because that's not the problem for you, right? There's all sorts of things that can cause preeclampsia. There is no one cause. And that makes it really difficult to treat, and it makes it really difficult to prevent. There's two real dietary patterns that have been associated with a reduced risk of preeclampsia. And it's what's called the New Nordic diet and the Mediterranean diet. And both of those are high in seafood. They are high monounsaturated fat diets and high vegetable-based diets. And when I say that, people are like, what about red meat? Red meat absolutely has a place in the diet. I am not pro extremes on either front. I'm not pro vegan and I'm not pro carnivore, right? I'm really not even pro paleo, because we miss so many things. The paleo diets are very renowned for creating iodine deficiencies, because we remove most of the iodine rich foods and most people aren't replacing that with seafood. They're missing it. They removed dairy, they removed the legumes, they removed a lot of these iodine rich foods and then didn't replace it correctly. So the Mediterranean diet has the most research in its ability to prevent preeclampsia. And it's because it's a nice balance of everything. We're not avoiding all the whole grains, but we're focusing on really good quality whole grains. We're not doing processed whole grains. We're going to do buckwheat as buckwheat porridge. We're not going to turn buckwheat into bread. If we are doing bread, we're grinding it fresh, hopefully, and making sourdough with it. We are adding in legumes. We're looking at grains and beans. They're really high. Manganese is this specific trace mineral, kind of like those poor little obscure B vitamins nobody talks about, but yet research shows has a really important place in the prevention of preeclampsia and cellular longevity. Everybody talks about blue zones. One of the cool things about blue zones is that soil is really high in manganese. And so the food that they're growing there is really rich in this really obscure trace mineral no one talks about. So Mediterranean diet stuff, right? They still eat red meat. They're eating lamb. They're eating all sorts of great things in Mediterranean regions. It's not anti-red meat. It's balanced red meats. It's balanced diet in general. They're using tons of fresh herbs. They're using a huge variety of fruits and vegetables. They're not afraid of sugar. They're not afraid of carbs. They're using good quality and they're balancing it. So that diet, because it hits so many antioxidants and it is so balanced, tends to have the best research to support its use in the prevention of preeclampsia.
Yeah, what I'm also hearing through everything that you're saying is just these waves of hyped up anything that comes into our consciousness through social media or the latest research, and things like the carnivore diet or things like paleo or keto or the MTHFR extravaganza that has taken place. It's just reminding me that in a lot of ways, they can be very helpful for certain people at certain times, but in a lot of ways, they are fads and we get taken along on this wave and we assume that this is the best thing ever until more research comes out and we realize, oopsies, like we thought again, we were smarter than the wisdom of traditional cultures and the wisdom of the body. It just keeps happening time and time again. So I love that you bring this up, and I love that you're bringing us back to the balance of something like the Mediterranean diet that has had the test of time and culture and multiple studies showing the benefit. But a real Mediterranean diet, like you're describing, is very balanced. It doesn't exclude any group. It is not extreme in any way. And by group, I mean food group. It's not extreme, and it focuses on quality. Like quality does matter. It's not just about the macro or the micronutrients. The quality of what we're eating does truly matter. So thank you for emphasizing that. There's so much that I want to get into with you, but I think something that's super important to talk about, because we did talk about the phospholipid bilayer quickly. I just want to touch upon the importance of choline and some of the research that's come out over the past several years. When I was in school, I graduated in 2013 for naturopathic medicine. Choline wasn't really a star at that time. And since then, things have shifted. So I'd love for you to let us know a little bit more about the importance of it in regards to brain development and anything else that you find pertinent.
Choline, a really cool nutrient, and it's actually part of the B vitamin family. If you look at the methylation system, we have those two different pathways. Folate pretty much just kind of works in that methionine cycle, but choline does so much more, right? Choline is going to get converted into betaine, which goes into breaking down homocysteine and methionine. But choline also goes into making things like your phosphatidylcholine. And phosphatidylcholines are part of, well, wouldn't you know it, that lipid bilayer. And we find choline deficiency being associated with higher rates of preeclampsia. Unlike all those nutrients I was talking about, we actually find that choline supplementation in acute preeclampsia actually helps reduce symptoms in really high dosages. So we're talking like 900 milligrams or more,
Wow.
like super high dosages, right? And that is multifaceted because it's going into restoring those lipid bilayers. If you go and look at Dr. Hart's research, and she talks about this shift and cholesterol gets the bad rap, which I think we all know now, cholesterol really isn't the issue when we look at some of these things that we talk about. But it's this idea of the Goldilocks method, not too hard, not too soft. We need it just right, like a monounsaturated fat. And so when we have possibly too many polyunsaturated fats, our poor little cells get floppy. And then cholesterol comes in and it says, no, no, we need you to stand straight up. Stop being floppy. We got stuff to do. But our body can overcompensate and throw way too much cholesterol into that lipid bilayer. And now it's too stiff. And if we have cell membranes that are too floppy or too stiff, then we can't allow nutrients and we can't allow oxygen into those cells. And therefore we get, wouldn't you know it, endothelial dysfunction. Choline in the form of phosphatidylcholine actually helps stabilize these cell membranes. And it's pretty cool. If you look at them, they're structurally very, very sound. And so by increasing choline, we help to stabilize these cell membranes. Obviously, choline in cases of like hyper homocystinemia, high homocysteine, can help bring that down. And we do know elevated homocysteine is associated with higher rates of preeclampsia as well. And that's via betaine. And the other thing it does is it goes into creating acetylcholine. Now, acetylcholine is a neurotransmitter. And in fact, it was one of the first neurotransmitters ever discovered. So it's a big signaler of a lot of these different metabolic processes in our body. And we do know low acetylcholine changes the electrical signaling of the blood vessels themselves, and then changes how they are able to contract and the blood flow, and can in it and of itself be associated with things like hypertension. So those are all of those systems. And of course, baby's brain, there's a lot of choline need happening in the brain. And most of it's going to be that phosphatidylcholine component that the baby is going to be converting. But from a preeclampsia perspective, it's mostly its role in either homocysteine or, I think more importantly, that balancing of the lipid bilayer on a fatty acid balance that changes the cell's ability to process nutrients and even clean out the oxidative stress. Other supplements, such as alpha lipoic acid, have been shown to even improve that lipid bilayer in conjunction with something like a choline more effectively.
Mm. Yeah, so it's allowing the gatekeeper, so to speak, to be better at its job. Yeah,
Yep.
that's a beautiful thing. And I'm glad that it's getting the attention that it needs. So many of these micronutrients and things that we don't hear about, these unsung heroes.
You look at the research on nutrition, it is very limited. And what you tend to find is that research tends to lock onto one nutrient because they found something and, oh, let's keep this going for a while, like vitamin D, right? Vitamin D is probably one of the most researched nutrients in pregnancy, to the deficit of magnesium and vitamin A and some of these other nutrients that also play together with vitamin D. There's still so many gaps in research as it pertains to pregnancy. Magnesium is a big one. There's really been zero studies on the physiological need for magnesium in pregnancy outside of the teeny tiny little bit that babies need.
Wow.
But if you understand the maternal physiology and how it changes from elevated estrogen levels and what estrogen does to magnesium absorption and utilization, and then the need in the uterus with the muscles and the vascular system, and even the need for magnesium for oxytocin receptor function. So you're telling me that the RDA for magnesium is 350 milligrams, yet in pregnancy, the upper limit for magnesium is also 350 milligrams. Who came up with this again?
No,
Right?
we can't square
This
that.
is, yeah, this doesn't make any sense. And it's based off of nothing more than how much magnesium citrate it takes to elicit loose bowels.
Hmm.
So it's not even based off of functionality of magnesium. So again, lots of gaps when it comes to nutrition. Once you understand the physiology, it makes way more sense, and it makes me happy to see studies like what we're seeing with choline, because choline's actually a fairly new nutrient on the block. We only discovered choline a handful of decades ago. I think shorter than that, I think it's been like in the 2000s, which is why it's so new, which is why the research is just coming out. It's interesting to see as more people become interested in the role of nutrition in physiology across the board. Obviously, pregnancy comes last in a lot of this research. To
Often, yes.
to see these new findings and to see some of these new nutrients that we're discovering. It's pretty fascinating. It's a fun time to be in the world of nutrition.
Yeah, I think so too. And something that you're bringing up, which again is a common theme on this podcast, is that we don't know everything. And reminding women just how important it is to tune into their inner authority, their inner compass, and their intuition on this journey, because we don't know anything. We don't have all the research. Certain studies can be a little bit flawed, like the powdered lemonade one that you brought up earlier, right? We are doing our best with the information that we have and tuning back into cultural wisdom, traditional wisdom, our bodies. What is our intuition saying? These are very valid accompaniments to the nutrition and the science and all of that. There's, of course, so much that I want to go into with you, but I do want to begin to wrap up. And before we do that, this is a birth focused podcast. I'd love to go into some of the things that you've seen that may support better healing after birth, that might prevent certain interventions, that can support mood in the postpartum period. You mentioned briefly the magnesium as improving oxytocin receptors. So these are big things that can really help the actual labor and birth process unfold and healing in the postpartum period. So I'd love to hear your take on that.
Yeah, that's another big topic. Chapter 12 of my book is all about the childbirth side of nutrition. And it's one of my favorite things to talk about because I feel like we are poised to make really positive changes in birth outcomes if we understand normal birth preparation physiology. And birth preparation, the cervix, everything starts changing actually way sooner than people realize. At 28 weeks, we already have changes in the cervix. The cervix is already remodeling in preparation for labor and delivery. And as we work on labor preparation, the number one thing that I focus on with my clients is happy, healthy cervix. Because we have to have a happy, healthy, remodeled cervix, or those contractions mean nothing, right?
So
You're going to
true.
push against a locked door. This is why we found that they started doing things like prostaglandins and those sorts of things in inductions, is because after decades of just pumping people with Pitocin, they realized we're missing a piece. Oh yeah, that cervix, it has to be soft. And so how it works is at conception, with the rise of progesterone, the collagen fibers of the cervix, because the cervix is just one big old chunk of collagen and cartilage, wind themselves together and knot themselves like a bird's nest. We don't want that cervix to open up. As our babies mature, they produce a ton of cortisol. And what cortisol does is it changes the type of progesterone receptor in the cervix. So it doesn't lower progesterone levels, but it changes what progesterone can bind it to. So we start to see those fibers unwinding. Slowly but surely. It's not like a rapid thing. This is happening over the course of months. as cortisol levels in response to the maturity of our baby. And so eventually we get to the point that these guys are all nice and unwound towards the end of pregnancy. The remodeling process requires things like glycine. Now, glycine is an amino acid, it's a protein. Outside of pregnancy, we consider it a non-essential amino acid. The body can produce most of it on its own. And then we get pregnant and it becomes what we call a conditionally essential amino acid, meaning you can't make enough of it and you got to consume it in the diet. The most rich sources of glycine are collagen and cartilage. Slow cooked meat with lots of collagen and cartilage. A whole chicken, a big pork shoulder roast, right, in the crock pot. All of that is going to be really rich in glycine. The other thing we need is vitamin C. Remember when we talked about vitamin C earlier and people who were like, oh, I'm craving vitamin C. Usually it's right around this time frame. They're like, oh my God, those cuties are really looking good, because you have to have vitamin C to stabilize this reaction, this change. We don't want it going too fast. We need to stabilize it as best we can. The other thing that happens is as our babies mature, there's a huge surge in estrogen in the body. And that estrogen produces those prostaglandins. And the prostaglandins are going to start to give these fibers flexibility. We need them to be wiggly, right? Now, most prostaglandins are coming from a specific omega-6 fatty acid called arachidonic acid. These are those fats that we've been told for probably most of our lives are bad, right? There's a specific one called linoleic acid, and it's found a lot in nuts and seeds. So I always tell people, eat a lot of these healthy omega-6 fatty acids. I don't want you to eat a bunch of processed ones. That's not what we want. We want the good ones. And the good ones are going to be found in a lot of nuts and seeds. And that will help stabilize some of this. We also need the proper estrogen production, which is going to come from the placenta. B6 plays into that a little bit. Then, as we get closer to labor and delivery, the next step in this process is the production of a compound called hyaluronic acid. You ever heard of hyaluronic acid?
Yeah, it's in a lot of cosmetics.
It is. Everybody who's heard about hyaluronic acid knows it from skincare. We don't want our wrinkles. We don't want to age. So what hyaluronic acid does is it takes fluid and suspends it between cells to give it plumpness. And that's what it's going to do here. We've made these fibers all parallel. We've given them some flexibility so that they can move. And now we're going to fill in those gaps with fluid. So now we start to see effacement and squishiness. We need that cervix to be squishy, and that's the role of hyaluronic acid. Hyaluronic acid is made from carbohydrates. It's a starchy compound. And in order for you to convert that, you need those prostaglandins that we were talking about before. Remember, everything's a stair step here. You need the cortisol to change the fibers. The changing of the fibers is going to elicit more oxytocin and prostaglandin production in the cervix. That's going to give those fibers flexibility. The more prostaglandins we get and the more flexible they get, eventually we hit a threshold in all of these things that triggers an increased production of that hyaluronic acid. We need the carbohydrates to do it. We need estrogen. We need prostaglandins. And then we need minerals, particularly that manganese that I keep bringing up. Poor little manganese. Nobody talks about him. Certain foods are known to promote more hyaluronic acid production. Now, you can eat hyaluronic acid directly through things like skin and cartilage, just like we talked about the glycine component. But you can also get all of the components that go into making hyaluronic acid by consuming foods that have lots of starches and manganese and minerals and all that. And that ends up being things like dates. I think we've all heard about the whole date connection, which is pretty
There
fun.
it is.
But you can also get it through things like sweet potatoes, white potatoes, bananas. There's a whole bunch of foods actually that give a lot of the same nutritional pieces that go into making that hyaluronic acid. There was a study done, it was a decade ago, where they compared induction methods. They took Pitocin, they took prostaglandins, and they took hyaluronic acid. And what they did is they injected the cervix with hyaluronic acid, and they found that the hyaluronic acid group had better birth outcomes, less cesarean rates, and lower C-section rates. No side effects.
Wow.
No negative side effects were seen in those studies. They decided it was a non-viable method because nobody likes getting injected in the cervix. What I took from these studies more than anything was how important the role of hyaluronic acid is for proper cervical development or remodeling. So anytime we're looking at How do we prepare somebody for labor and delivery? This is the first thing we think about, because if we don't do that legwork way back at 28 weeks, we can't really play catch up at the end as fast as we want. Then we're like, oh no, we didn't do all that work. And we have all that work to do before that oxytocin can do its job. Usually right around that 34-week mark is when we start to see oxytocin receptors and that side start ramping up. Thyroid hormones actually play a really big role in that, and nobody talks about that. There was a really cool study called the Consortium of Safe Labor. It was a big nationwide study. I think there was 19 different hospitals and clinics involved, 100,000+ people in the study. What they found were people with subclinical hypothyroidism in the third trimester, and we're talking a TSH of 2.5 or less, which is still considered normal by many standards, had more complications in their birth experience. They had longer first stages of labor. They were less likely to present in spontaneous labor. They had more premature rupture of membranes without the onset of labor, and they had higher cesarean rates due to failure to progress. They also had higher hemorrhaging rates.
Wow. Yeah.
So when we're talking about that labor preparation side, there's a lot of things that go into that. One of the nutrients that we don't talk about enough when it comes to this is vitamin A. Most people are told to fear vitamin A in pregnancy, right? Due to birth defects. That only matters in the first 3 weeks of pregnancy when most people don't even know they're pregnant.
Really?
Vitamin A. Yeah.
Wow. I'm shocked about that because it was very much stressed in my education to avoid.
Absolutely. I have a whole section in my book on this too. Most of the studies on vitamin A as it pertains to birth defects is based off of some really shoddy studies done in the 70s where they used water-based vitamin A, not fat-soluble based vitamin A. And when you use a water-based vitamin A, the liver doesn't recognize it, so you become toxic in it pretty quickly. This is back when they talk about that whole folate thing. Back when we thought some of these types of fat-soluble vitamins that we had converted into water-soluble were going to be better because we could bypass those rate-limiting steps. We could bypass the natural physiology.
We're so much smarter.
Oh, no, that was a problem. We should not do that. So vitamin A was one of those. This is why people who are on Accutane, which is a water-based vitamin A complex, have to be on birth control because there's a high rate of birth defects with that. Not so much with diet. I always joke, if you're eating that much liver, you like liver way more than I'm giving you credit for. Okay. In the third trimester, what we find is there is a 6-fold increase in vitamin A receptors in the uterus in the third trimester.
Wow.
And that vitamin A is really important for the genetic expression of oxytocin receptors. No vitamin A, no oxytocin receptors. You can't genetically express them without the vitamin A. We're told to avoid it. Obviously, liver is one of our biggest bangs for our buck from a vitamin A perspective, but you can get vitamin A in other sources like chicken skin, fish skin. Those have a lot of vitamin A in it, actually. And then you have all your orange veggies, your sweet potatoes, your butternut squash, your carrots. All of those guys have beta carotene, which is a precursor and can be converted into the active form of vitamin A. It's about a 15% conversion rate, and you have to have thyroid hormones to do it.
In comes the thyroid again.
I'm a big movie buff, so I tend to quote a lot of movies, but I feel like Kostas from My Big Fat Greek Wedding. Give me a condition, any condition, and I can tell you how the root of that condition is thyroid.
Yeah, and you're not wrong, right? Especially when it comes to maternal health. And I think what you probably see as well as what I see as well is in the postpartum period, how many women have to just deal with hypothyroidism or Graves' disease or some kind of autoimmune like Hashimoto's. So really taking care of our thyroid. Yeah.
Really common postpartum diagnosis. Most women who are diagnosed with thyroid issues, they get diagnosed postpartum, but the damage was done in pregnancy. Nobody caught it.
Yeah. Yeah. Thank you for bringing this to light. I really appreciate the depth that you're able to go into this, all the nuance that you're able to bring to this conversation, and reminding us that we don't know everything. And some of the recommendations might only be relevant for a few weeks in our pregnancy. And we're making these blanket statements that aren't really serving the health of mothers and babies and the whole families. So thank you so much for this. As my last question, Sarah, I always do this little preamble. There is a profound imprint that takes place when a new life is entering this reality. And we hope that it's the imprint of love and safety and trust, this big welcome party for the baby. These are all signatures of oxytocin. Sometimes that's not the case. Sometimes what happens is it's an imprint of mistrust, of unsafety, of survival mode, of protection mode, for whatever reason, of fear because of what happened in the birth experience. As I mentioned, almost half of women are describing their experiences as traumatic. And I'm so glad that we had this conversation because you brought to light the oxytocin receptors and the health and the reformation of the cervix, which we haven't talked about on this podcast at all. And so the negative imprints, they're not permanent. There's a lot that we can do to repair, but why repair when we can prepare, when we understand the knowledge that you've outlined so graciously in your book and what so many of the guests on this podcast have offered? We can make a difference. And when enough families are supported, we can have a whole generation that is raised with this imprint of love and safety and trust. And I just think we'd be looking at such a different world if that were the case. And all of that is to ask you, what would you like to imprint onto the ears of the listeners, Sarah? It's a lot of moms to be, it's a lot of new moms, it's a lot of families preparing for birth. It's also a lot of women who want to use that womb space, creative, life force energy to birth something beautiful into the world, a mission-led business, a creative endeavor, whatever it might be. What would you like to imprint onto their ears?
Oh, I think so many things. I think that I always say prevention is easier than treatment. I know there's a whole group of people who are preparing for pregnancy. We have people who are in it who may already be experiencing a complication. And I have so many sayings. Prevention is easier than treatment is always one of them. So if you're in that preventative phase, do your due diligence, get some labs done, look at optimization, see what you can change in your life that reduces that risk of things later on. Once you become pregnant, it's really hard to change. If you're pregnant and you have something that's happening, you did nothing wrong, right? We're only as good as the information we've been given. And it's never too late to make a positive change. You can talk to somebody who is versed in the prenatal care world and gets the proper testing. You may have to fight for it with your medical providers, you may not, but you may have to advocate for yourself. And again, it's never too late, right? If you're on the backside of that, when you've just gone through a pregnancy where something went awry, there's things that you can do. And I know that from talking to clients who have gone through something traumatic, sometimes all they want to know is why. Why did this happen? And try to find somebody, find a functional medicine provider, find somebody who is versed in pregnancy care who can help you do the detective work in figuring that out. Because there's a lot out there and it can get overwhelming. For those practitioners out there or the people who are thinking, how do I get involved in this? How do I help make this change? Because I truly believe that nutrition and functional medicine are the future of maternity care. And I think that working in maternity care is the most important phase of life to work with patients because we're changing the next generation. And even if we can't make 100% changes in the patients we're seeing in the clinic, hopefully by working with them and optimizing and helping them achieve the best that they can, we're setting that next generation up for fewer complication. And it's through the support of the mothers we are seeing now that we will start to change these horrible statistics that we have developed over the last several decades when it comes to our health here in the United States. We have to start with pregnancy. A lot of these things come from things that happened in pregnancy. So if you're out there thinking, I want to get involved, I want to do this, I think the most important thing is just to spread the knowledge that nutrition has a place in maternity care, to spread the knowledge of what functional medicine has to offer, which is the connection of the dots in the physiology, and let people know that this is even an option. Most people don't even know this is available to them. And So it starts there. It starts with education. We're only as good as what we know. And right now, there's a lot of things people don't know. And that's the number one thing, is that they don't even know that this is an option. So if you're out there, if you're listening, spread the word, tell people about functional medicine and nutrition and how this works and all the great things that we have the potential to give our clients.
Yeah, absolutely. I couldn't agree more. Not even knowing that this is an option is an issue. And hopefully, I am able to amplify your voice. I really hope that it is transmitted into the field and received by the ears of everyone who needs to hear it. Sarah, if people are very curious and want to know more, want to dive into their own health with you, or if a practitioner is like, where can I get more information? Is there a way that they can consult with you? How does it work if someone wants to reach out to you?
Yeah, absolutely. So I do have my private practice clinic. It's Sacred Vessel, and it's a functional maternity clinic. We do functional medicine, and we specialize particularly in maternity care. So I work with clients through the preconception through postpartum phase. That's what I do. They can reach out to my website. It's functionalmaternity.com. You'll see two pathways. One is for people who are interested in becoming patients, and the other is for practitioners who may want to either consult. I do offer continuing education courses for providers. So that's kind of the hub for that. They can just click on the I'm a practitioner versus I'm a client, and that'll take them over to that side of things. So I try to have one website to rule them all as best I can. I am on Instagram. It's functional.maternity. And I post mostly towards practitioners on there, but I have a lot of people who are pregnant or trying to get pregnant who follow. It's a lot of research based. So sometimes it's pretty deep. I don't give a lot of treatment protocols on there because I don't believe in protocols. So my job on that page is just to share the research that I'm finding and to share the information that I have found over the years.
I so appreciate it because you are also bringing to light the importance of individualized medicine. And that is, I assume, one of the reasons you don't really like protocols that much. Thank you so much for this, Sarah. This is an episode that I am going to listen to over and over again, that I assume many of the listeners are going to listen to over and over again, because it is so jam-packed with research, wisdom, and very relevant information for people in this very precious, very important phase of their life. So thank you again. I'm going to list all those links in the show notes, easy access for anyone interested. And so much gratitude for you for taking the time to do this. I really appreciate it.
Of course. Thank you for having me. It was a pleasure.
Thank you so much for joining us on today's episode of Rewire for Birth. We hope you found our discussion inspiring and empowering. If you enjoyed the episode, we would greatly appreciate it if you could leave us a review on your favorite podcast platform. Your reviews help us reach more listeners and spread the message of holistic, empowered birth experiences. Feel free to mention what you loved about today's episode and how it helped you feel more prepared and confident about your birthing journey. Your feedback not only encourages us, but it helps other moms-to-be find our podcast and join this incredible community. Together, we can make a positive change in the world of birth. Until next time, stay empowered and keep rewiring for birth.